Hello. So I'm Mihir Vyas of Apoplex Medical Technologies. We provide medical software, cloud-based, to detect atrial fibrillation. I'm here, pleased to introduce Dr. Lucio Danna. If I could ask you, Dr. Danna, to say a few words about your background.
Yes, and nice to be here with me as well. Thanks for having me here. My name is Dr. Danna. I work at Imperial College. I'm a consultant and neurologist and in stroke medicine, and I also have an honorary senior lecturer position at Imperial College.
Excellent, excellent. So you certainly know the stroke business. Now, I understand you did quite an extensive study a couple of years ago, which subsequently was published in the British Medical Journal. I wonder if you could expand on the reasons you did the study, how you did the study, and anything that you'd like to talk about the results, and we can go on to talk about the results.
It would be a pleasure. Yes, our study focused on the management of the patient with a transient ischemic attack, TIA. We all know that the importance of the TIA stands with the risk of stroke recurrence, because there is a 30% of patients that can have a stroke after TIA in the short term. Therefore, it's very important to set up the best management in this patient with the right technology in order to prevent new strokes after a TIA. It's important to understand that a very important proportion of patients with a TIA have the TIA caused by the atrial fibrillation. And we have to understand that it's very important to detect as early as possible atrial fibrillation, so we can change the management in terms of anticoagulation to prevent by 70% the risk of having another stroke. The idea behind the study was to understand how we can improve the patient experience in our TIA unit rapid assessment at Imperial College. So in the first part of the study, we recruit patients for 6 months with a possible probable TIA that were seen by our stroke physicians and neurologists, and then they went through our routine pathway. This means that they were discharged from the clinic, and then they were having a ECG Holter around 24 hours on average, and then we monitor how long did it take to have the Holter done and reported. And in the second phase of the study, instead of using the routine ECG Holter, we decided to use the Apoplex SRA Holter that was implanted soon after the TIA. The primary goal of the study was to compare in the two arms of the patient the detection rate of atrial fibrillation. Also was important to monitor, to compare the time to have the ECG Holter done and reported, and first instance also the numbers of stroke recurrence. In our results, we can see that the two populations were very similar for baseline characteristics. They both had a Holter monitor implanted for 24 hours on average, with no difference from the statistical perspective. Was very different the delay from the time of the TIA to have the ECG Holter done. On average, the routine patient had the Holter with an average of 50-60 days, compared to the SRA Holter that was implanted within a day from the TIA event. In terms of results, we can see that the group of the patient with the SRA Holter had a significantly higher detection rate of atrial fibrillation compared to the normal routine pathway. Plus, also we can see the number of stroke recurrence in the first arm, so the patient with the normal routine management, was significantly higher compared to the patient treated or assessed with the Holter by SRA Apoplex.
Okay, so it sounds like the adoption of the SRA detection software that we've provided has reduced the time of detection.
Yes, it was a significant result, because the way it worked was that normally in our clinic, after a diagnosis TIA, the physician can request an Holter, and the patient has to attend the cardiology department to have the ECG Holter. And then this sometimes can take a lot of time. Yeah. In our project, we measure this time, and on average it was 50, 60 days to have this halter done. On the other hand, using Apoplex X-ray technology give us a lot of flexibility, because at the moment we have this halter that can be used and then can be managed directly by the stroke doctor without involvement of the cardiologist. This means that you can choose your patient, and then as soon as you see the patient that you think can be the right candidate to have the X-ray halter, you can consent the patient, and the patient can be sent home directly from the TIA clinic this time with the halter, rather than attending a cardiology appointment. This has cut significantly our waiting list, the cost as well, and then no necessary delays.
That's fantastic. The fact that your patients are dealing with just your department and not having to deal with the timetable in other departments.
Yes, this is an improvement. There is an improvement in the patient experience, because from the patient eye, you can see the patient is sent home from the TIA clinic by a stroke physician who explained the reason why you need to have an halter. And then after, for example, a week, we'll come back to the same TIA clinic in the same department. We'll see the same doctor who will detach the halter from the chest, will download the data, and in only 5 minutes, you will have the results, and then explain to the patient, in case of confirmed AF, what to do next.
So the result is there in 5 minutes.
Yes.
So pretty much immediately while the patient is in front of you.
Yes.
And I expect it's much nicer for the patient to just deal with your unit rather than be passed around different departments in the hospital.
Yes, absolutely. I think that from the patient experience perspective is a massive advantage, but also from the physician perspective, because as a stroke neurologist, we wanted to cut any delays, and then having a very complete assessment in a very short period of time. In our study, we documented 1 day to have the halter compared to 60 days is something very significant for us, important.
Now, since then, of course, it was published in the British Medical Journal, and a lot of people have read it. I certainly come across a lot of people who talk to me about it, which is very nice. You've since then, as a department, gone on to adopt our services throughout your department. Now, in general, within the NHS, you have to put a business case through. Now, is this the process you went through? Did you have to make a business case to use our service?
We made two main studies with Apoplex. This one that I mentioned was about outpatient setting. Yes. Previously, I did another study about inpatient, so the use of Apoplex when we had the patient are in our HASU, in our stroke unit. And then because of both significantly show the increased detection rate of atrial fibrillation, but very importantly, the Apoplex is able to shorten the time delay from the onset of stroke to detection of atrial fibrillation. I decided to write a business case, and then with the help of the managers, we were able to buy halters from Apoplex, and at the moment we are currently using, not in research, but in our clinical setting.
In your clinical setting. And of course you'll be able to continue this with your bedside monitors as well.
Yes, we are continuing using the Apoplex for inpatient, outpatient as well.
Inpatient, outpatient. Well, that's excellent. How do you think, perhaps you already know, but the use of our service has changed the way that the department works? Has there been any sort of, there will be some small changes, but is there a larger general change?
But I will define it as a revolution because
fantastic.
The way we're working now is completely different. The way we were working in the past.
Such a big difference.
Completely, it's a revolution. So I make you a practical example.
Yeah,
so we discharge a patient that doesn't need maybe physiotherapy or any inpatient stay from our HASU, and in the past we had to discharge and then waiting for the halter to be done. This, as you see mentioned already, it takes a lot of time. Yeah. And then at the same time you have to follow up the patient till all the monitoring, ECG monitoring has been completed. Yeah. This can add delays on delays, and then also increasing the waiting list for halter department, ECG cardiology department, but also for our department. Now we are discharging the patient directly with the Apoplex, and then we have huge flexibility. We can decide together when the patient can come back, see the physician, we can download the data, and then we can discharge for our care. We are cutting waiting list time and then cost as well.
That's fantastic. So it sounds like, I know this sounds a little bit basic, but whereas before the patient was going to a number of different departments, it is a one-stop shop.
Yes.
For within the stroke unit, and you can deal with the entirety of the patient problem, particularly with relation to atrial fibrillation, as you are.
No, definitely is the use of technology, of course, with the scope to improve patient care and patient experience is definitely something that we are aiming. We would like also to constantly update the way we do things at Imperial. I believe that new technology can help to make the right automated system to basically improve the patient care, and then especially very important to achieve a better diagnosis, a better definition of the cause of the stroke.
Right. Now, I know in your pursuit of adopting our system and our service, that you had a number of hurdles to cross, not on the clinician side, but on the cyber security and the digital security side. Now we've accomplished that, so it should be easier for you to proceed in the future.
Yes.
Because this is a completely separate side of things. As we work on the cloud, we have to have all these extra things to do. I also was wondering, are you going to be looking to monitor how it goes in the next 6 months? For instance, we did talk about monitoring a study to see the patient satisfaction survey, yes, or even a staff survey to check that the thoughts in the study, the thoughts in the business case, and then we have to prove that these are delivered. Now, you've said that a lot of this is already delivered, but in the long term, to see some sort of satisfaction in the patient care and just ease of use. For instance, will you be monitoring your reduction in waiting times or bed stays, or is it reducing the number of stays in overnight stays that individual patients have? These
are all good things that I think that are requirements to do when, especially, you start with a new service.
Right.
We are pioneering the new service in our country, if you think so. So we are using a new device that is a automated process, not relying on the cardiology department. I absolutely believe it is something that is totally new. But like everything new, it's important to monitor and to control. From the patient perspective, you mentioned already, the idea is to involve the patient, of course, in this new system, in our department, to understand what is the patient satisfaction. When we were doing these trials with this study, informally I approached the patient, and we were very happy to see always the same face, to come back to the same room again, and then especially to have the report in 5 minutes. This is a massive game changer for us, also from the eye of the patient, if you think, because you are discharged from a clinic, then not with the promise that you have a test that will come in 2-3 months.
Right.
But you already are discharged with an investigation, with a test that is attached to your chest. And then you're coming back after a week, and then you will see your same doctor who will send you home a week before that can download the data and give you a response in only 5 minutes. That can be very reassuring in either way, if you have or not AF. Also, automatically, if there is a AF detected in monitor, the same doctor can prescribe the right medication and send you home with the right prescription. So, from our perspective, it's very important that this will be seen in our future. Also, we will do a formal survey without involving the patient. Is important in our NHS always to understand what is the best way to satisfy our patient. And then for the future, we will see, of course, we want to continue to collaborate with Apoplex.
Of course.
And then the idea, of course, to combine clinical experience with new research, new ideas, in order to develop better our service.
That's great. And from what you've said, the patient experience is much improved because the diagnostic starts straight away if we can use this service within the stroke units rather than have to rely on a separate cardiology unit. I was just wondering, how do the cardiologists feel about this? Are they losing some work, or
No, we have a very good relationship with our colleagues, with the cardiologists. I think that they understand our frustration, if I can say so, in the sense that we know that if after an event, a cerebrovascular event, a stroke or TIA, whatever you want to call it, is of paramount importance to detect AF soon after the stroke.
Yeah.
As I already always say in our meetings, the audit or the QI project that I did and the research is not aiming to blame anyone, it's not aiming to blame the service. We all know that our colleagues are doing the best that is possible. Unfortunately, it's a real life experience, but not only in my hospital, but in other settings. I believe that there is always a right way to collaborate further. We always need, stroke is a cerebrovascular disease, brain, but there is a huge interconnection with the heart. So we always need the collaboration with our cardiologists, and then we are aiming to continue along this path.
But seeing as what we provide is purely AF detection, which is a very niche thing, from the cardiologists at other hospitals that use our service, have found that their workload has been improved within the cardiology department, rather than being overloaded with extra. That they have their own work and then they have extra work from the stroke unit. They are missing this extra work, and I suppose this keeps a budget within your department. You're not expanding your budget to pay the cardiology department as an internal market.
We are using these new devices, helping us, of course, to cut costs.
It has cut costs.
Yes, because we are using our internal device inside our department. We are using our workforce. But also can help the cardiologist. We can select the patient that really need another type of device, like the normal ECG holder. We can have a better patient selection. But Apoplex help us also to cut the so-called indirect cost. So for example, number of appointments that can go miss, the waiting list in our outpatient clinic, and so on. So I believe that we have a better way in which we can optimize our time, and then at the same time improve patient care.
That's great. That's great. It sounds like it's you've gone through it in a very logical and scientific way where you've got to, and you're going to continue in that way to monitor the effects of using and the benefits of using our service. So from what you've said, it's the cost savings are there, as well as, I think you used the word revolutionary, because it has changed the way that you're working, which is really nice to see.
Yes, it's a revolution, another way to work. Of course, it's a system and that we are continuously is under monitor. We will audit on a regular basis to see where we can improve. But I believe that nowadays it's important to offer a different type of care. So we have to optimize the delays, and then when, of course, it's possible, because the data are quite clear, so we have to investigate a much better patient after TIA of a stroke. The final goal is to reduce the stroke risk to have another stroke. TIA is a condition where the patient has a minimal deficit that is resolving within 24 hours. What we want to avoid, having the patient with a massive stroke that will remain disabled for life or will lead to mortality.
Well, I have two more questions. First, I wanted to really talk about the SRA. I think gives you 3 results. It gives you no AF detected, and increased risk. Now, how helpful is the increased risk? How do you approach a report that we send back that our algorithm and on the cloud comes back with an increased risk assessment?
But at the moment, because we are doing something extremely new, I want to say that there is not really much guidance about.
Yes.
I personally advise my colleagues or my junior doctors to have a patient-to-patient approach on an individual basis.
Right.
For example, a patient that can have a high risk of AF, given the high very CHA2DS2-VASc score or some imaging characteristics that can make me think a possible underlying AF, after, for example, a very prolonged monitor, we sometimes refer to the loop recorder directly, and then the patient will be under the watch of a cardiologist for the next 1-2 years, for example. If the patient is another type of stroke where it's making me think more a lacunar etiology, after a prolonged monitor with the Apoplex, I think that maybe we can close the case. We can think that there are other alternative causes to the leading to the stroke. Regarding to the increased risk, again, patient to patient, patient by patient, maybe sometimes we can decide to repeat another Apoplex Holter, or in that case, we can, according also to the echocardiogram findings, we can define maybe to request another Holter and to involve the cardiologist for advice.
I see. So it can lead to ongoing diagnostics, which is always better for the patient.
Yes. At the moment, we need more data about. We need more data because, again, we are pioneering something totally new.
Yes.
We are in uncharted waters. But again, with the evidence that already suggests that this system is quite reliable. But we need more evidence, of course. And then we have to make our own experience, collecting more data, and in the future we can define better pathways.
Okay. And we offer two services, the SRA and the SRA Plus. The SRA will give you the report on detected AF episode. But a doctor within the department would have to check it, maybe even have to send to cardiology, whereas the SRA Plus is our own cardiologist having pre-checked when the software has actually detected some AF. I think you chose the SRA Plus. Was there a decision to make on that, or was it a straightforward decision?
But relatively straightforward in the sense that, again, with the aim to cut any delays, we prefer to have the complete service from Apoplex, and then the involvement of a cardiologist is important, is of paramount importance for us. We decide to have directly the report full ready without having other delays to ask for a second opinion and so on.
Okay, because this is a report that this confirmation we can provide within 24 hours, which I think is still much quicker than
the usual pathway.
The usual pathway. Well, look, I'm really pleased that you chose to do the work, the research into this, and have adopted this. I look forward to seeing your ongoing thoughts and results. I'm sure they're very good. I'm glad things have been revolutionized a little bit in your department. And if there's any future studies that you do, we'd be certainly very interested in.
It would be my pleasure.
Yeah. Okay. Well, thank you very much.
Pleasure.
Dr. Lucio Danna.
Thank you.